This one is just showing what I already just talked about now, which leads outwards. So if you're looking at an ECG, they usually arrange it this way. Most cases, you have your 1 AVR, 2 AVL, 3 AVF. So all the AVs are going to be on the same line like this. 1, 2, 3 for each other like that. And then you have your V's, V1 to V6 on this side, right? Typically. So we know my 1 AVL is definitely lateral wall together with what? V5 and V6. Then V1 to V3 to V4 rather is on my anteroceptor wall. And then I have my inferior wall, which is 2, 3 AVF. I have ABR on its own, which typically is looking at the right ventricle, right? So you're going to be required to read each one to just figure out if you can find the changes and correspond that to the location, right, of the infarction. All right, so what are the ischemic changes I'm looking for in ECG? One of the earliest, if somebody is having a myocardial infarction, within the first few minutes, seconds to minutes, the earliest ECG change is usually what? Hyperacute T wave. So the T wave will be very, very tall. Looks like this. It looks super tall, as tall as the KRS complex or even taller than the KRS complex, right? So we call this hyperacute. It's one of the earliest findings you're going to see, right, during infarction of the heart. The problem with this is that it is not specific for the heart, right? There are other conditions that may cause hyperacute T waves, like most commonly hyperkalemia, right? Can also do this. So always take this with a grain of salt. Remember, you're interpreting ECG based on the clinical presentation. We're not interpreting it alone. So if somebody, for instance, presents with crushing chest pain, older patient, or typical angina chest pain, crushing substernal, releasing to the jaw, and the patient has all these risk factors for atherosclerosis, guess what? And I see hyperactivity, right? I'll put MI at the top, not hyperkalemia at the top. But if I'm looking at somebody that is relatively no risk factors for atherosclerosis, they don't have that crushing chest pain, they presently present maybe tachyarrhythmia or bradycardia, or your heart is racing, things like that. And I say hyperacute wave, then I might suspect hyperkalemia, right? More likely than MI, right? So you're interpreting an ECG based on the clinical picture, not isolated, right? Cases. So, but this will be one of the earliest changes you're going to see. Now, the ones that we should know for sure that an examiner is likely to give will be these two, the ST changes, which is something you're going to see typically within minutes to hours for an infarction. And what are the implications of ST change, right? Basic implications. So what do you mean by ST? So remember here, so there's something called J point. Let me look at this one. Okay, look at this one here first. So here we have, let's say P wave is somewhere here. We have the PR segment, QRS complex, and then here, so this point here where the KRS ends, and then the ST segment begins, that's your J point. J point, this point here, got the J point. And the J point is usually what? In a normal ECG should be in line, right? With the PR segment. We call that isoelectric point. Yeah. So basically it's a point where there is no net positive or negative charge, right? Generated by the myocardium. So it's like a straight line, isoelectric point. In patient with infarction of the heart, the resting membrane potential of the heart is altered. So that isoelectric point will be shifted, and this ECG will pick it up, right? So that will reset the J point here in somebody with an infarction or ischemia. There are two types of infarction the heart can undergo in terms of occlusive, right? Second to occlusion of the coronary artery or atherosclerosis, right, of the coronary artery. The first one is what subendocardial infarction, and the second one we call it transmural infarction. And let me show you what we mean by that. So if you're looking at the heart like this, so this is the heart muscle, and what is the most superficial layer of the heart? Pericardium, right? So pericardium is here. It's the outer, the sac surrounding the heart, right? P for pericardium. Between the and then we have the myocardium, this VM, the thickest layer. And then, of course, we have what? Endocardium, which will be innermost layer, endocardium. Where are the blood vessels that supplies the myocardium? Where are they? They usually run somewhere here, like within this space, pericardial space. So they run here, and what do? They now send what? Penetrating branches, right? Deep into the myocardium. Okay. And let's say the direction of blood flow is this way, right? Direction of blood flow. Send penetrating branches. All right. So, Doc, I'll give you two scenarios. First scenario, right? There is a 90% occlusion, right, of this artery. It's not 100%. So there's about 90% of the coronary artery occlusion here. It's not 100%, it's not totally occluded. It is somewhat narrow, but there's still some blood, right, going through. Tell me which part of the myocardium will be most susceptible to death in this case. Is it going to be the whole thickness of the myocardium? There's going to be a particular area that will be more likely to die if there's significantly decreased blood supply, but not complete occlusion of the coronary artery. What do you think?
I think the farthest part is gonna be the most
Which part?
The part that's like farthest away from the
Farthest away, right? So the part that's farthest away and closest towards the endocardium, right? So this part here, makes sense, will be the one most likely to suffer injury. And this will call what? Subendocardial, right? Myocardial injury or infarction. So this is super important, right? So depending on the lesion, coronary artery, there's like an anteromatous plaque there, maybe it's even ruptured, especially thrombus. You're gonna see the pathophysiology when you look at the ischemic video in more details. But then it goes without saying, if the occlusion is not 100%, only the area farthest away, like you said, will be impacted. So these areas that are closer to the pericardium will be spared, but the deepest layer closest to the endocardium, right, which is what we call the subendocardium, myocardial, and myocardium, will undergo infarction or injury. And this usually presents as what it presents as ST, either ST depression or normal J point. So basically, if I look at the J point in this point here, in this patient with this kind of injury, subendocardial myocardial injury, they're going to present with what? Their J points will actually be lower. It's either going to start at a point lower than the PR segment here. So instead of starting at that straight line, the same line as the PR segment, it's going to start at a point lower, but it's going to be at the same location. It's not going to be elevated. So we call this what? N-STEMI, non-ST elevation MI. So there will be no ST elevation. There will be no elevation of the J point in this case because of the location of the infarction. So we call that, or you can either say a normal J point or you say ST depression, but the point is it will not be elevated. So we call this N-STEMI. However, if the lesion is 100%, if the lesion in the coronary artery causes what 100% occlusion of the coronary artery, what happens? The whole thickness of the myocardium, right, will be impacted. And this is what we call transmural. Transmural means what? Full thickness, the full wall. Infarction involves the full wall, 100%, the full thickness of the myocardium, transmural MI. And what will you see? What happens to J point? The J point actually gets elevated, right? In this scenario. So you're going to see elevated J point. And this is what we call STEMI, ST segment elevation, MI. So look at this ST here, depression. So this is my J point. Typically, this should be where my isoelectric line is with the PR segment. But look at the J point here. The J point here is starting lower, right? Began low, or is basically depressed, lower than the isoelectric point, right? Hence ST depression. But in this one, this should be my isoelectric point here, which corresponds to the PR interval. But then look at the J point here, starting at a point higher than the isoelectric point, right? Hence ST elevation. So an examiner can give me this. So what can we deduce from ECG, from the ST depression or elevation? I can deduce two or more things. The first thing is what is the lesion in the coronary artery? That's the first thing. Is the coronary artery completely occluded, or it is a subtotal occlusion? It is occluded, critically occluded, like up to 90%, but not 100%. So an examiner will ask you that. Yeah, ruptured plaque with platelet thrombus causing 100% occlusion. If I see ST elevation, that will be my answer. If that's not about what is going on in the coronary artery. But they give me ECG, I see ST depression. Ask me what will I see in the coronary artery? It's going to be ruptured plaque plus platelet thrombus, but leading to what, less than 100% occlusion. Okay, ST depression. They can also ask me, what will I see in the myocardium itself? Not the coronary artery, not the myocardium. I see ST elevation, I'm going to see transmural, total wall, total thickness infarction of the myocardium. If I see ST depression, I'm going to see only the infarction of the subendocardial myocardium, the deepest layer. So far, so good?
Yes, sir.
Good. And this is what we want to know at this level. We should be able to identify those changes and then correspond them to the appropriate coronary lesion and myocardial infarction, degree of infarction. Right? Some other rarely, at this level, probably won't be tested per se, will be, or but in case you see it being mentioned. So other features of ischemia will be T-wave inversion, right? So T-wave inversion is something you can also see. So you're going to see the T-waves that remember our T-wave should be like this in patients with infarction or ischemia, where there's decreased blood flow through the coronary artery. That's part of the heart. So you're going to see, or the leads that supply that wall of the heart. So you might see inverted T-waves. Yeah, that's another feature. And then finally, there's something called Q-wave as well. Q-wave is something you're going to see in somebody that has had infarction for a long time. So it takes days or weeks or months for this to develop. And what that means is in our KRS complex, the Q-wave of the KRS complex is going to be wider or deeper than usual. So normally Q-wave usually just is very, very small. And then you have your R, which is the biggest, and then you have your S-wave. For a patient with infarction, cold infarct, or the suffered from ischemia in myocardium, that part of the heart has undergone infarction and fibrosis, you're going to see the Q will be either wider or usually it's going to be deeper. It might be as deep or as long as what S wave or even the R wave, right? Downwards. So we call that Q wave. So those are going to be maybe some other terms you might see in the vignette being used. Oh, patient has Q waves on ECG. You want to go high. Maybe patient has an infarction at some point before. But patient has inverted T waves. That might mean ischemia. But definitely ST elevation depression, those ones I wanted to know for sure. Know how to identify them on ECG as well. And then the corresponding, right, pathophysiologic implications as well as pathologic findings. Those are going to be definitely tested for all these findings here. For the other three, I have an idea, but at this level, not too important just to remember. All right. So let's do some, go ahead.
What did the T-wave inversion stand for again?
Ischemia still.
Okay.
Everything here corresponds to ischemia infarction of the heart.